Hello and welcome back to Communicable, the podcast brought to you by CMI Communications, ESCMID's open access journal covering infectious diseases and clinical microbiology. My name is Angela Huttner. I'm an infectious disease doctor at the Geneva University Hospital in Switzerland and editor-in-chief of CMI Comms. I'm joined by my co-host, Eren McCreary, fellow editor at CMI Comms, ID pharmacist extraordinaire, and director of infectious disease improvement and clinical research innovation at UPMC in Pittsburgh, USA.
Hi. Excited to be here. And we're very excited to welcome two esteemed guests today to discuss vaccines, a topic that really shouldn't be controversial at all. And we're excited to dive into it. Like most things, understanding the secret sauce, or really how we built it, often helps us appreciate the greater good and makes things more relatable. While our listeners are mostly healthcare providers and researchers in the microbiology, virology, and bacteriology space, we hope today's thoughtful discussion on vaccine platforms and technology helps us all have better conversations with our families, friends, and patients about the importance of vaccines.
Our first guest is Barney Graham, infectious diseases physician and scientist. He has a BA from Rice University, MD from the University of Kansas, and PhD from Vanderbilt University. He retired as Deputy Director of NIH's NIAID Vaccine Research Center in 2021 and is now Professor and Director of the David Satcher Global Health Equity Institute at Morehouse School of Medicine in Atlanta, Georgia. He's an inventor of vaccines and monoclonal antibodies approved for human use to prevent or treat RSV, COVID-19, and Ebola. He's authored over 500 scientific publications, is a member of the National Academy of Sciences and the National Inventors Hall of Fame, and has received multiple awards for the advancement of science. Time magazine has recognized him as one of the world's 100 most influential individuals and a Hero of the Year in 2021, and as one of the 100 most influential individuals in health in 2024. Barney, that is quite an amazing biography. We are so honored to have you here. Welcome to Communicable.
Thank you. It's a pleasure to be here, to see you again.
Our second guest is Gary Kobinger, Canadian immunologist and virologist, currently professor in the Department of Microbiology and Immunology at University of Texas Medical Branch, Texas, USA, and until recently director of the Galveston National Laboratory, the Biosafety Level 4 facility. Gary has held previous professorships at the University of Manitoba and the University of Pennsylvania. Additionally, he was the chief of the Special Pathogens Unit at the National Microbiology Laboratory of the Public Health Agency of Canada in Winnipeg, Manitoba, for 8 years. Gary is known for his critical role in the development of both an effective Ebola vaccine and effective treatment, that being ZEBOV. His work focuses on the development and evaluation of new vaccine platforms and immunological treatments against emerging and re-emerging viruses. Finally, Gary also created and co-leads GUARD, which stands for Global Urgent and Advanced Research and Development, a nonprofit organization that implements low-cost strategies for research and development of vaccines and diagnostic tools against emerging and neglected infectious diseases, thereby improving access to healthcare for populations worldwide. Gary, welcome to Communicable. So glad you're here.
Thank you for the introduction, and I feel honored and very happy to be here.
We are very glad both of you are here. So as our listeners know, we always start with a get to know you question. We make hosts go first, so guests don't have to. So here it is. Gary was actually on the road the first time we tried to record this. That's a long story, which we will not get into. And he was meant to do this recording while on a very long road trip, I think from Texas to Canada. So we thought of this question at that time. What is an odd or otherwise memorable travel experience you've had during a road trip or other travel? Eren, you first.
Sure. So I love to travel. I travel quite a bit, both for work, for some professional engagements, and I grew up moving a lot. I was actually born in Bangkok, Thailand, for those of you who don't know. And I went to Norway in summer of 2024 because we saw Taylor Swift in Amsterdam, and then we decided to go to Norway for a week. And we walked into a restaurant in Bergen, Norway, and I hear someone go, "Eren McCreary?" I was like, "What?" And I look over my shoulder, and standing there was a girl who was in my undergraduate sorority. I hadn't seen her since 2009, and we just happened to run into each other in this restaurant in Norway. So it's just like, as cheesy as it sounds, like the world is so small, we're so connected. And so it was a good little reminder.
Very cool. I think it's really hard to actually narrow it down to one. I thought about this so much, and the thing I kept coming back to, it's just so memorable to me. I doubted whether I should share it because it was such a stupid thing that I did. When I was, I think, about 24 years old, I was a medical student, and NYU allowed me to go to West Africa to do an elective there as a student. So I was in Bamako, Mali. It was like my first couple of days there, and I had to go up to the hospital, the Point G, which is really high up above the city on this beautiful plateau. And so I got myself up there, and I was like working in the lab, and I was trying to be really good. And when I finally got out, it was getting dark. And I thought, okay, well, I can just grab a taxi and it'll be fine. But nobody was around. One of the only few people I could find was somebody who was probably a med student, and he was very kind, and he said, there will be no buses to Bamako. The only way to get to Bamako now is to get on the back of my little moped. The voice of my dad in the back of my head saying, like, don't do anything stupid. And I was like, well, okay. So I did it. I got on the back of this moped, and this guy flew down the cliff. It was really, really terrifying, but it was absolutely beautiful because it was twilight, just the energy, the air, everything. At any rate, I felt that I had to take a chance, kind of trust the universe. And this young man was an absolute gentleman, took me exactly to the door where I needed to go in the town of Bamako. And it was just something I've never forgotten. It was a beautiful experience. I wouldn't recommend that anybody ever do that. And I hope my daughters are not listening.
It turned out okay, but don't ever do what I did. Well, we're glad you're here, Angela. Barney, what's yours?
Well, I've traveled a lot in Africa and Asia working on HIV vaccines and also Ebola vaccines and antibodies in Congo. And so I've had a lot of travel disasters that I don't really want to recount. I guess I'll tell you about the time I had the most fun. In Eastern Africa, we collaborated with IAVI and Walter Reed groups to do some of our advanced clinical trials for HIV vaccines that we developed at the VRC. And one trip was to Uganda. And while we were working in Tebe and Kampala, we took a trip down to one of their peripheral sites in Jinja. Jinja is on Lake Victoria, and it's the head of the White Nile River, the river that flows north. And at that time, they still had about 3 or 4 miles of rapids. And so Nelson Michael and I were at the head of the raft that we went down to conquer the rapids on the White Nile River coming out of Jinja. And now, coincidentally, my daughter-in-law, her father grew up in Jinja. And so the world is small. It's a very interconnected place. And I encourage everybody to learn more about all its little nooks and corners.
Oh, wonderful. And how cool that you got to do that with Nelson Michael, who, by the way, taught me a lot of stuff in 2014 when there was the Ebola outbreak. Big shout out to him. Gary, you.
I'll tell you a short one that was kind of interesting. It's work related. It was in DRC, the Democratic Republic of the Congo, 2006 or 7. Going to an outbreak of Ebola and being part of an international team for controlling the outbreak as quick as possible. So I was part of the first wave of people deploying. Everything was in a bit of a rush to get on a small plane to go to the site. And getting close to the site, the problem was that he didn't want to land. He was suggesting we had to jump because he didn't want his wheels to touch the ground where Ebola was. So after a bit of talking, we convinced him to land the plane because we couldn't just jump and throw the equipment out. And that we would clean up the wheels with bleach and everything so that he feels good about this plane. Finally, he landed and then took off so quick. The interesting part of this trip was that we started the outbreak, but actually we were dropped off with 3 laptops, 3 guys, 3 cell phones, and 2 bottles of water. And that was it. We had to wait 7 days until finally the equipment arrived. So it was an interesting being dropped in the middle of the outbreak, but without any of our equipment to do diagnostic as we were supposed to do. Everything turned well, by the way. And on top of this, that was my first outbreak, and it was the first of many. You learn quickly to bring at least, which I was the only one of 3 lucky enough, brought a change of clothes in my little backpack together with my computer in case this kind of thing would happen. Yeah, plan B.
Yeah.
Wow. That's crazy. That makes our travel stories seem so silly, Angela. Yeah.
I know, right? We pale in comparison. I thought my
Absolutely.
moped down the mountain was pretty cool, but jumping off a moving plane actually takes the cake, definitely.
That is a life experience for sure. But aligned with the fact that we have two of the world's masters on vaccine construction here with us today. And so we're going to jump right into the nuts and bolts of how this is created. So Barney, let's start with you. Your work on a vaccine for RSV ended up laying the groundwork for the COVID-19 vaccine design. Can you tell us about that RSV vaccine and how it served as the model for the COVID work?
Yes, I started working on RSV 40 years ago, back in 1985, motivated by HIV that I saw during my residency training to become a viral immunologist. I asked Peter Wright, how do I become a virologist? He handed me a vial of RSV and said, see if you can grow this and come back 6 months later and tell me how you did. Anyway, the people in that lab were very helpful to me, and I spent 20 years trying to understand the vaccine-enhanced disease back in the mid-60s with the very first attempts at making RSV vaccines, and spent most of my time trying to understand pathogenesis. And then in 2008, when Jason McClellan, a young postdoc, joined the Quang lab at the VRC, we launched an effort to understand the structural biology of the F protein, the fusion protein, which is the main target on the virus for neutralizing antibodies. And so epitope by epitope, known epitopes at the time, we started solving structures. And eventually by 2012, we were able to identify some antibodies that could hold the thing together, and we were able to capture the prefusion state of the F protein. Unlike all the efforts on HIV that had come before, where conformational evasion was just one of the problems for neutralization, solving the conformation of the pre-fusion form of the F glycoprotein before it rearranges to do its thing for viral entry really is pretty much solved the problem for immunogenicity and effective immunity against RSV. So turning the pre-fusion F into a vaccine antigen worked. And that led to trying to extend those observations to other envelope viruses like coronavirus. And so as Jason moved to universities, Dartmouth and then UT Austin, we continued our work on trying to show whether stabilizing fusion proteins in their pre-fusion state would make them better vaccine antigens.
Yeah, it's pretty amazing to see that hard work pay off. And as you say, it worked. So how does it feel to see the RSV landscape today? We went from nothing to now we have multiple vaccines, multiple antibody products.
It's very gratifying and exciting for me to see babies under 6 months of age having ways of being protected, both from maternal immunization or for direct antibody transfer to the young infant. So that's fantastic. Having vaccines for the elderly is kind of a bonus, and what we now need to do as a field is solve the problem for the 6-month to 5-year-old child who also has a lot of disease, and we don't have a solution for that right now. We also don't have a solution for getting these vaccines into low-income countries, which is part of the reason I'm now at Morehouse School of Medicine directing this global health equity program.
Do you want to tell us a little bit about that?
Well, I left the VRC at the end of 2021. I left federal service and moved to Atlanta, Georgia. I joined the faculty at Morehouse School of Medicine. This is a relatively small medical school. It's in its 50th year of existence this year. It is focused on health equity and health justice. This is part of its mission statement. It's a wonderful place to be working if you're trying to solve problems of equity and fairness. The thing that I think has changed is mRNA coming on the scene and showing to be effective and very safe creates a new possibility for distributed manufacturing because it's a synthetic product. The supply chain is being solved. It can be done on a small footprint with a small amount of equipment, a small number of people. It can do small batch manufacturing that could serve regional purposes. So I think with mRNA, it creates options that were never achievable when you needed a whole campus full of bioreactors. There's several places on the African continent, in South Africa, in Senegal, and Rwanda, that are making good progress in making mRNA. So it doesn't solve all vaccine problems, and it's not going to be the tool for everything, but it opens up the possibility of expanding research capacity in low-income countries and eventually regional manufacturing in places where they haven't had access to new products in the past. I work and consult and advocate for those kinds of things. And then most of my work really is trying to work with the young students there and help them find international experiences to open up a vision for their life in public health.
This is great to learn about this whole global health aspect. Gary, what has your experience been with mRNA vaccines?
Well, as Barney said, the big advantage is the manufacturing is easier and it can be more local. That said, of course, you need a cold chain, which means that brings, for some location, an added layer of complexity. mRNA vaccine is a very promising new tool that is important, that will play an important role, but it won't solve it all. And there is still a very good platform to tackle the issue of vaccination and protect population. But right now, one of the biggest hurdles is acceptance of those vaccination campaigns, and not so much the tools to vaccinate. Of course, we don't have vaccine against everything, but there is a lot of good tools now, and mRNA is one of the most recent and definitely very promising one. But it doesn't prevent or remove from the roles of other very good vaccine, like polio vaccine, and all others to keep moving forward and protecting population against infectious diseases. So I think it's always a matter of risk-benefit, not only in terms of the vaccine to the recipient, but also from the platform perspective to what are the risk-benefit at the population level, country level, what are the plus and the minuses, the costs associated with this, what do we need in terms of infrastructures. Some vaccine platforms are easier to use in specific environment than others. The more options we have, the better prepared and able we are to protect population with tools that are very well adapted to the needs, basically.
Yeah. I'm going to pivot now to a totally different vaccine. You mentioned Ebola before. Gary played a leading role in developing the currently licensed vaccine against Ebola, which is the rVSV-ZEBOV vaccine. Ervebo is now the trade name, which is strikingly effective and now used routinely in the field. That vaccine is certainly not mRNA. It's a live vaccine. Can you tell us about it? What were those challenges in early development? And now that we do have mRNA technology, what do you think of rVSV-ZEBOV?
I think it's still a great tool. And by the way, I'm going to start by saying that the real leader into that early vaccine development was Dr. Heinz Feldman. He really spearheaded that project from the beginning. VSV Ebola was not produced as a vaccine initially. It was generated to study the glycoprotein, the component of Ebola which binds into target cells, and to study it in a different virus, which was VSV, so that it could be used actually in level 2 as well. VSV is an animal virus that is not known to cause disease in humans, although there is documented infection. Farmers, for example, that have antibodies. So it's recognized as a very safe animal virus that doesn't infect humans. And so to put the glycoprotein from Ebola into that context made it possible to work in level 2. And that was really the initial tools that was developed. So it was really basic biology and virology.
Just for our audience, can you tell us what level 2 is?
Oh, I'm sorry. Yes. So Ebola is, we all usually understand it's a virus that is quite dangerous. It needs to be studied in the highest level of containment, which is level 4. So there's 4 levels, 1, 2, 3, 4. 1 is your kitchen counter, so to speak, but more in a lab setting. Level 2 is more for protecting what you work with and not necessarily yourself. So there are viruses and bacteria that are not pathogenic. They don't cause disease, but you want to protect them from the environment. You don't want contamination. Level 3, you're starting to protect yourself. And level 4 is really full-fledged protecting yourself from a deadly pathogen. Here you are in a spacesuit. So VSV, the vaccine, as of today, was made in level 2, basically as a non-pathogenic virus, a virus that doesn't cause disease in humans and was made to study. But this evolved with Heinz. Why not use this as a vaccine? I think early on, when the first data came out of those studies, the immune responses were extremely good. very robust. It appeared from the start to be a very promising vaccine platform. That said, I think in our little community, we were thinking, well, this is a good gold standard, but I'm not sure that it will ever be a clinical product because it's still an animal virus modified where we added the glycoprotein from Ebola virus and removed the one that was to the VSV virus. We knew everything can be done, and from a regulation perspective, it's just a matter of showing safety data. But the issue was perception. We thought that it's not the first live vaccine, as we say live vaccine, which is based on a virus that replicates, or a vaccine core that replicates. Yellow fever is a good example of this, and it's, I think, probably the most efficient vaccine out there, one dose for life. But it was still at the time where perception mattered. Aside from this, there were other platforms like adenovirus, like DNA. RNA came later on, but they seemed to be very potent and maybe with a better safety profile or a better acceptance profile. We moved VSV initially as more gold standard for other vaccine platforms, trying to get to that level. In 2014, we had a clinical grade lot to move into a phase 1. At the time, I was the chief in Winnipeg, and I offered it to WHO. I was not the only one, by the way. GSK offered their adenovirus-based Ebola vaccine. And the first offering was declined, but a few months after that, as the situation worsened in West Africa, then clinical trials were initiated and part of the history of this vaccine. Now, I think it's a phenomenal vaccine still. I think that long-term protection is not well understood, and that we may need at least a booster and maybe something else. A booster with the same or a different vaccine, I think will be useful. But again, as you said, there's other platforms. They were there at the time. Some are new, like mRNA. Are they going to be able to bring more benefits, again, to fight that infectious disease? Maybe. I don't know. I think data needs to be generated, and we'll see.
I will tell you, Gary, I actually did not know it was directly from you, this donation of this experimental Ebola vaccine to WHO in the summer of 2014. I was here in Geneva, and I think WHO was, of course, very happy to have access to these vaccines, but that vaccine had never been tested in human beings in a trial, let's say. There were some, perhaps, lab workers who had received the vaccine, but it had not yet been tested in a trial. So they did ask us at the University of Geneva to rapidly put together that phase 1 trial, which we did. But I'll tell you, we had a terrible time. There's something about VSV that it was developed in the States using VSV. This is the vesicular stomatitis virus as the vector. That's a beautiful idea for the United States, for North America. But VSV has no presence right now in Europe. So that as the vector was a nightmare for our regulatory authorities. In fact, because we're talking about Switzerland, right? VSV infects livestock. Just letting people know who might be just like regular infectious disease doctors in the hospital. You may not know this, but VSV, like Gary said, it's a virus that infects livestock, maybe some human farmers. It's not a real problem for humans, but livestock, I mean, that really interferes with milk supply, right? So for Switzerland, this is a country that lives on cheese and chocolate, and those industries are so important. And we had a devil of a time trying to get that through. I mean, we almost didn't have a trial. We fought tooth and nail to get that aspect of the trial approved. And in fact, for our healthy volunteers who did this phase 1 trial with us, we had to collect their saliva. We had to collect their urine. We had to make sure they were not shedding VSV. They were not allowed to have contact with other human beings. They were not allowed to go on farms after vaccination. It was really a big deal for a European center to trial this vaccine in a place where VSV has no presence right now.
So I guess, Angela, for our listeners that are less familiar with the science, that may have been a little alarming what you just said. To clarify, how did this story end? After receipt of vaccine, are people both protected from Ebola and unlikely to harm their farm animals? Is that true?
Yeah, I can absolutely assure everyone that here in Geneva, we were testing the very highest doses of this VSV vectored Ebola vaccine. We had the highest doses, and we really were checking everyone. We were checking blood, urine, saliva. We found it in the blood. This is a normal thing. There was viremia. This is what we wanted. This is what we expected. This is how the vaccine takes. But we did not find it in the urine. We did not find it in saliva. And so there was no shedding that we could find. And no, there was no cow that was infected. We had no trouble at all. The viremia, the vaccinemia, was very transient itself, even in the participants who got the highest doses.
This was one of the point of discussion, including in Africa, where people are actually closer often to cattle and animals. A lot of families have their own animals, and it's actually a big part of their economy and the wealth of a family. But the issue was more misdiagnosing. VSV infection does present a bit like foot and mouth, but it's not as damaging as foot and mouth at all. But it's a worry that if you have the symptoms of foot and mouth, then the vet may trigger responses to that, including culling of animals, without that being foot and mouth. But it turned out that there's not a single documented transmission of vaccinated individuals to any animal, including in Africa, again, where hundreds of thousands were vaccinated, and many of them were close to their animals, including the same day, because they were coming to the center, being vaccinated and going back home. Nobody was staying there in a phase 3, and after that in active outbreak setting. So this was all a point of discussion and theoretical problem that was discussed extensively, but at the end turned out to not be an issue in real life, basically. But it was good to document that people are not shedding the vaccine. The discussion even went, can somebody that is vaccinated infect another person that is not vaccinated? But also this was never documented, somebody that infected or co-vaccinated another person that was not directly vaccinated.
Yeah. This has been fascinating to learn. I think you both have talked about two different platforms, so to speak, putting a virus in another virus, and then everything we discussed with the mRNA platform and how that was translatable across multiple viruses. So to get a little more macro level, both of you have been advocates for prototype pathogen preparedness, or developing vaccine designs in advance for the family of viruses so that if there's an outbreak or a pandemic, you're readily prepared to pivot and to have that science and technology available, which is really just amazing. Can you tell us a little bit more about that? Barney, let's start with you and maybe go back to the COVID space for a bit. How, in your eyes, did that set you up for success in 2020? And then how is that going to work both today and in the future?
Yes, at the Vaccine Research Center that opened in 2000-2001 timeframe, we had been responding to all these outbreaks, and there was smallpox scares in around 9/11 in 2001. It went to West Nile, SARS, the first SARS, and avian flu, on and on and on, chikungunya, MERS coronavirus, and then Ebola in 2014. So our work on RSV and then on coronavirus, solving structures of similar type fusion proteins, and all those responses that all had to be reactive instead of proactive. And then Zika came. And Zika, since we had done a DNA vaccine for West Nile, we quickly made a DNA vaccine for Zika and got it into Central and South America within about 16 months. And yet that was too slow, for the epidemic was already over by the time we got the vaccine out there. And so we started thinking about how could we do better and be more proactive, and taking the example of DNA, going from one flavivirus to another, or structure-based vaccine design, taking a fusion protein from different envelope viruses, even across different families. And the paper was being written between about 2015 and 16, 17 on a prototype pathogen approach to pandemic preparedness, and taking a family-based approach to this problem. And then we implemented that idea after 2016 because we found that we had a multi-phase response in the government to Zika. The DNA was the most immediate. The secondary was going to be mRNA. So we ended up testing 3 different mRNA products in our monkey model during that 2016 timeframe. And then the third component was going to be Steve Whitehead's live attenuated approach that he had taken for dengue. Well, anyway, 10 micrograms of mRNA was as good as 4 milligrams of DNA. So it was extremely better and more potent. And something had changed between 2013 and 2016. Something in the formulation, the delivery, the sequences I'm not sure, but RNA all of a sudden was working. So we started a collaboration with Moderna in 2017 on the coronaviruses and the paramyxoviruses, with Nipah as a prototype for paramyxos and MERS coronavirus as a prototype for corona. And by 2019 had shown that either DNA or protein using the vaccine designs we had would protect against lethal challenge in animal models. So we had already paid for and were prepared to take the Nipah vaccine mRNA into phase 1 clinical trials in the first quarter of 2020. And then on January 6th, found out that this could be a beta coronavirus and flipped from the paramyxo family to the coronavirus family for a demonstration project. Talking about the prototype pathogens and then doing that, and then the coronavirus is coming out so quickly, I think spurred a lot of other groups, WHO, CEPI, and others to take on this family-based or prototype pathogen approach to, not that it will solve all problems or that everything can go that fast, but it is at least a way of organizing the work. And so WHO and NIAID have probably pushed this the farthest at this point, but I think it is a way forward to at least to organize the work. And there's now groups all over the world organizing family by family called the Corks, the WHO organized Corks, to work on these different virus families.
Gary, any comments?
I think it's fascinating. We see often what works, but we fail to see what was less optimal, basically, and everything, all the work that was done, left, right, and center to basically get to a solution that is, in our mind, at least, always work in progress. Whatever we have, we can improve. And that's why I think it's important to not get too focused on one tool, but to keep your eyes on all the possibilities, including the future possibilities. Especially for earlier career scientists, it's very important to hear about all the work that goes around what was done. The path to that solution is at least as important as the solution itself, especially when you want to understand a bit better how these vaccines are. And it's not only a matter for early career scientists. I think it's very useful for people that are curious about vaccination, and I think it helps also with acceptance of vaccine in the population for people that can have access to that kind of knowledge. Your exercise here, this podcast, is quite useful, I think, because it can be accessible by anybody.
Yeah, I like that you segued into the public wanting to access this and might not understand the science to this degree, but having the experience and the familiarity may enhance acceptance. Any advice you have for how you educate the Gen Pop in encouraging people to enroll in the early trials, and how you educate the medical community in moving us toward a broad acceptance of vaccination? Once vaccines are approved and proven safe and proven efficacious, why is there still this hesitancy in some to uptake the vaccine?
I think that's probably the most important topic right now for vaccinologists. I would start by saying I think what's key is transparency when you're on the side of the development of vaccines. And from the first step to the end, completely, it should be a fully transparent process. You would be surprised how many people from the community contacted me with questions and sometimes challenging what publication they could find online and how curious some people are. I think this needs to be encouraged. People that are in the community that have questions, they should be able to ask those questions. They should be able to challenge every step of development, every little platform or big platform or whatnot. Today, I still think that protein-based vaccine, which are the first very early generation of vaccine, are still very important. They have still a very important safety profile. And if they work as that kind of platform, let's do it. And I'm saying this because people are more comfortable with those because they have been around for so long and they have had time to gain more knowledge. But what's important is really to communicate to the population, to people. And ultimately, I will say this, it's my opinion, maybe not shared by all of you and maybe not shared by everybody, but I still personally think that vaccination is a personal choice. I think that if we cannot convince people that the vaccine is good for them, we need to go back to the board and communicate it better because it's very easy. Vaccine have saved more people than everything but one solution. And that solution is clean water. Well, anybody on this planet, I think that has a sense of understanding of infectious disease, understands that drinking dirty water from a puddle in the middle of a country where it's always warm or hot is not a good idea. And drinking, by the way, contaminated water in Canada is not a good idea either. So again, vaccines have saved so many lives. Let people ask, let people understand. It's not a perfect intervention. There are side effects. Let's communicate them. Most are extremely mild, but for some people, it could be more severe. Let's communicate all this. Let's educate people. Let them make their own educated choice and not force vaccination on people. I think this is a very thin line to walk because people are being forced into something. They don't often react the right way. And I think right now what we are experiencing is mainly due to a lot of push, in some extent, very, very hard push where people were being told, if you don't get vaccinated, you're going to lose your job. We're going to fire you. I think it's a very risky position to take, personally. I think it's better to convince those people with hard data and show them the benefit of vaccination, let them decide. There are exceptions to this. If you decide to work in a cancer department, you don't want to get vaccinated and you put those patients at risk, then you shouldn't be there. But you shouldn't lose your job. You could go to another department and work there. As an example, like everything, there are exceptions. But overall, a large majority of people wants to get vaccinated because they know that they're going to be a bit tired if that's the side effect. It's nothing compared to risking your life and getting the disease or being handicapped by a disease that leaves you with severe consequences of the infection. When I was a kid, there was a kid that was in my class that was in crutches from polio. You don't see them anymore. And I hope we won't see them back, although this polio is still active. And this is one of the, I think, infectious disease that we shouldn't see around anymore.
Thank you, Gary. I will tell you very transparently, one of the reasons I really wanted to do this episode is because our listenership is doctors, it's healthcare professionals, it's pharmacists, it's people who are in that chain between real vaccine experts such as you two and the general public. And we are now living in a time when one of the deputy directors of the CDC just said, I think people now need to go to their primary care doctors to get their information there. The CDC does have some level of a credibility problem because of current leadership. And so now our listenership is going to be frontline. So it's really nice to try to help them to understand how these vaccines work so that they can then turn around and inform their patients, their families, school teachers, etc., who are coming to them with questions about safety, efficacy, the value of getting a vaccine, yes or no. It requires more time, more effort from everybody involved because, like you said, it's often case by case, giving more information, reassuring people. But it does seem to be overall quite effective in not letting any one group be polarized and be too Manichaean about how they view this tool among other tools. Barney, do you have any comments?
I agree with everything Gary just said. The first step is listening. We have to listen better. There are no bad questions. We have to be able to answer questions without being defensive. And I agree that teaching is better than mandates. I grew up in a farming country in Kansas, and I've always said that a Kansas farmer will vaccinate his animals. They will vaccinate themselves if you just explain why. If you tell them what to do, they won't do it. I can guarantee you, if you tell me what to do, I am not going to do it. But if you teach instead of mandate, I think it can be much more effective. The other thing is I think we have to do a lot more work with our young children because our 3rd and 4th and 5th graders can understand biology a lot better than we acknowledge. They can be the teachers to the parents and the grandparents. So we have to do a better job of teaching biology to our young people and also teaching critical thinking. And that kind of thing is being lost from U.S. educational facilities, at least. Teach about how to think. Thinking about how you think is an important concept. It will help people when they hear things that may or may not sound like they make sense. They can ask, what is the motivation behind that? Who's going to gain from their associations or their investments if you do it their way instead of this way? And so I just think there's a lot of educating that we could be doing both to the general public during a crisis and to our children before the crisis.
I think we all empathize with this. It's like raising teenagers. Like, you can't tell them no, or don't do this, or this is bad for you, or this is good for you. They have to come to that realization on your own. So I couldn't agree more. It's like every single patient is different, and we don't like that answer as a society or as a global community, because that's more work and that's challenging and that takes more time and skill, things that we don't have, right? And especially in the American healthcare system, physicians, APPs are increasingly under pressure to see a patient every 4 minutes, right? And that's not enough time to sit, especially with a new patient, and get into their own personal motivation or fear in why they would or would not accept a vaccine. But the only way we're going to move this needle is to get to the individual person and have them make an informed decision about what's best for them. So something I think about a lot is time's the only thing we're never getting back, and it's our most precious human resource. So
this conversation is making me remember something. So in 2021, full disclosure, Gary Kobinger approached us here in Geneva because we had this population of healthy volunteers who had participated in our 2014 phase 1 trial testing that VSV-ZEBOV vaccine. And Gary asked us, would you be willing to track down some of those volunteers and do another phase 1 trial where we test a booster vaccine in those patients who'd already been primed with the VSV-ZEBOV vaccine? I will be very happy to hear Gary tell us about it in detail, but this vaccine was a DNA vaccine. And I'll tell you, we had a wonderful group of participants. Our volunteers are very special people. Many of them are Doctors Without Borders workers who were going down to Africa back in 2014, but a lot of our volunteers were local Geneva residents who simply wanted to help and wanted to get the world closer to a vaccine that could work against Ebola. Some of them, of course, would be a bit fearful about a new vaccine and a DNA vaccine of all things. So we organized some information sessions for this population that we were hoping to recruit into this booster trial. And Gary very kindly got online from Canada, and we just talked to the participants. A lot of people dialed in, and Gary was able to just speak very honestly about potential safety issues. This is what we know. This is what we don't know yet. This is why we do trials, of course. And you said something, Gary, that I thought was so great. You said, we're eating DNA all the time. Every time you eat plants, you're eating a lot of DNA. You're ingesting a lot of DNA. I think that really reassured a lot of people. And ever since then, I actually think about that. I think, all these people who are so scared about what am I putting into my body, actually, it turns out you're putting like 2 kilos of DNA every day. And if we can take the time to talk to people and put it in terms like that, it really kind of helps. We had a very good recruitment rate for our phase 1 trial. Recruitment was not a problem. Gary, any words on that?
It was very interesting, 2 things in my view. First, that the number of people that wanted to participate was very high, and that was a great sign. The second thing is why we picked DNA is because it worked in all the models we had been studying, but more importantly to us was that the safety profile was the best. The side effect was barely detectable. There was some pain at the site of injection. It's not because it's DNA or it's RNA or it's anything. It's the needle that goes in through the skin and the muscle does create pain, and it's part of the side effect. So really the level of side effect is extremely low. And it made actually them more interested in the vaccine. They came back and said, well, if I'm in the placebo, can I then get the vaccine at the end of the trial? So that yes. Created another level of discussion.
Yeah. It was the first time I had done a vaccine trial where people weren't having tons of reactogenicity. Everyone thought, I must have gotten placebo. I didn't have a fever. I didn't have anything. But anyway, actually, I'm ashamed to say we've taken longer than we thought to get the results in because Gary is doing all kinds of interesting antibody assays. And we're really getting into depth about innate immunity, humoral immunity, lots of results to dig into. And so we actually are submitting those results hopefully this week, Gary. So that paper will come out, we hope, soon.
Can I add one thing? I just want to point out that mRNA is in every living thing on Earth.
You're so right.
Yeah. These are things people may not even know. They may not put that together, but it helps to hear things like this. We're ingesting RNA all the time, and DNA for that matter. Yeah. Gary, I want to come back to one thing. We learned that Barney is working very hard on access to vaccines in different settings, and you are too. Can you tell us about GUARD, this organization that you founded?
Yeah, it's basically a not-for-profit that is trying to advance diagnostic, vaccine, and therapeutics at very low cost. So overall, as of now, after this was starting in 2018, so after 7 years, we are working about less than 10% of the average cost of others that are in that same sphere. Sometimes we're actually lower than that, but on average. And so it definitely reduced the cost. But it's not all positive in the sense that when you don't have investors that see a return, then of course it's a bit more difficult to raise money. But I think more and more, there's two things that are happening, I think at minimum, is there's more interest into the way and strategy of advancing tools. A lot more young investigators are coming to us, are very interested, and they want to help. They want to contribute. They don't want to make millions and billions. They just want to help others. And so that attitude has changed, I think, at least from my generation. And I think it's great. And we see more scientists of all ages and clinicians really spending more time. And we sit also, again, I think it's great to see Barney, after leaving this last big job, spending more time into access. And let's face it, a lot of those infectious diseases, at least that are close to my heart, are neglected tropical diseases. And which means that, economically speaking, there's no future for those vaccines the way they are now. It doesn't mean that you cannot save thousands and tens of thousands of lives from devastating diseases. And it's not only the disease, it's the impact on the community, the economic impact. If there's an Ebola case in a village, trust me, the village shut down. There's no trade, there's nothing happening. It's beyond the direct damage of this infectious disease. We are right now starting more in the sphere of diagnostic, because also this is the first thing that you need to do. What is the disease? You need to identify it, and then you need to differentiate who is infected from who is not infected. And a lot of those tools to diagnose the tests that are being developed are also very expensive, when in fact you can develop them at very low cost. So that's where we are now. It's not against the for-profit format. It's complementing the for-profit format with an approach that will serve population that otherwise don't have access to those tools at all, zero. And so that's where we're starting. But behind this, I think the narrative that we're also pushing for, and that when I have a chance to talk to an executive in Big Pharma, by the way, we've had a tremendous communication and collaboration with Merck, not only for VSV vaccine, for other things as well. They want to solve problems. They want to help. Of course, they are a for-profit company. And for us, there's nothing wrong with that. It's, again, the fact that there's a lot of diseases for which there's no solution that are economically viable, so there's no investment. And that's where we try to be. And we see this as being complementary. The narrative we're trying to push to Big Pharma is, why don't you all apply what I call naively the Walmart concept? Before Walmart, retails was working at a 20-30% profit margin. Walmart came in and said, we'll do less than 3% profit margin. I will make more money because we'll do volume. And I'm trying to push that narrative on pharma. Why don't you treat everybody on this planet? Reduce your profit margin that sometimes is 10,000%. 10,000%. It's unreal. Then, of course, only a very small portion of the world population can access that kind of expense and afford that kind of expense. And so let's lower the profit margin and let's go on volume. Let's save everybody on this planet for every disease. I don't think it's going to slow investment personally, because there will be more money generated for doing more research and development. But again, it's a shift from the past. And I think it's great right now to see more people getting involved in everything that lowers cost, that promotes access, and to see the younger generation also being so motivated. Honestly, I'm so impressed. The people that came to us to work, very talented young investigators. And it's honestly looking really good, in my view, for the future to lower costs and improve access.
That's awesome. I think we covered really nicely. There's a lot of beautiful things about the current system and then a lot of opportunity for reform. So this is a question for both of you, and maybe Barney, you can start us off. If you could do anything, so with everything we've talked about today, if you had unlimited resources and the global collaboration we're moving toward increasingly, what's next? What vaccine or infectious diseases challenge would you want to take on?
One of the premises of this idea of working on the viral families is because there's 26 viral families that are known to infect humans. Some of them are more studied than others, but the whole premise is to generate the basic research data that we need on all the different viruses and not leave anything out. You could still prioritize within categories, but it's a way of covering everything. And we now have the technological tools to do so much. We could solve so many problems. I think we could solve 80 or 90% of the problems we have right now ahead of time if we would focus and if we could convince high-income countries that it is in their mutual interest to work with low-income countries to solve regional problems before they become global problems. And that would benefit everyone. And it would also build the research capacity in low-income countries. And building the human capital, people who know how to do these things, is the first step in getting to a point where you can do some regional manufacturing. And so if we really want to solve and reduce pandemic threats of the future, we have all the technology tools right now. We just don't have the policies and practices or will to really deploy the resources that are needed. The high-income countries can supply resources and low-income countries can supply manpower and samples and the things where most pandemics emerge. So if I could see anything happen, it would be that. And part of that is to get everyone involved. Make sure we don't leave any talent on the earth untapped. There's so much talent right now everywhere that is either dismissed or ignored or just blocked from accessing all the resources they need to do their very best. So that's what I would love to see happen.
Gary, how about you?
I think what Barney just said is amazing. And I think actually we're moving towards that. I'm quite optimistic that it's not too far. The knowledge that is necessary, as you said, for 90% is there or close to be acquired. So I think from that knowledge perspective, we're very well positioned. Again, I think the intent is there. And coordinating all this is where it's complicated and it's difficult. But again, it's a matter of the more we talk about it and we see the benefit and we explain the benefit, the more likely we are to move towards this. More from a maybe a little technical perspective, if I would have to throw myself in the future, I would love to see everyone being able to develop their little diagnostic tests and being able to develop the vaccine and therapeutics they may need from information they would download from the internet, from the government, their healthcare provider. And I'm just using the image of a coffee machine, which most people have in the house. So this is a technical challenge, but I think it's still somewhere where we could be going. And that would be quite interesting also from a cost perspective if we would get that technology. On the second level, we're talking about vaccine. It's basically modifying the immune response and preparing the immune response to fight back an infectious agent. There's a lot of knowledge that came out of all these studies and also basic immunology. This field could grow not only to protect against infectious disease, and there's a big footprint in the cancer area where there's cancer vaccine. But you can imagine also that all this immunology could allow us to modulate and adapt everybody's immune system in the most beneficial way. For example, limiting the appearance of autoimmune diseases or making them more tolerable or disappear. And that involves also, in my view, allergies that are growing. If you look 50 years ago and today, allergies are a much bigger problem now. And so the vaccine is one field that is growing, that has already a lot of challenges in front of them. But there's a lot of fun to have there and fascinating work, I think, that we'll see being done in the future.
I'm an optimist for sure. I try to be a pretty positive person, which some days is harder than others. But I remember when the checkpoint inhibitors first came out in the oncology space, and I remember just like running up and down the halls of the hospital, like being so excited because I was like, guys, finally, instead of pouring toxic things to try to kill evil things in humans and hurting humans along the way, we've flipped the narrative to now we're just going to make the host better and we're going to augment the things that can help within the host. And what amazing science and just mindset in general. Like I thought that was so phenomenal. And of course, now those are the most commonly used, highest billing drugs globally. I think that what you just said about understanding the immune system and how do we really just continue to make the host better is just really cool science and a cool direction. With that, thank you for sharing your time. Thank you for everything you've done for patients around the globe with your teams and with your research, jumping out of planes and all of the things that we did to get here today.
Well, look at us sitting in different continents talking to each other. This wasn't possible in 2001 and 2 when the first SARS came. If the first SARS came before we had any structural information, before we had any real tools to do much of anything, before we could do these kinds of video calls with everybody together from everywhere, we would have been sunk. And so if you want to be optimistic, you can thank the universe for holding COVID back for 20 years. 20 years earlier, it would have been even worse.
Well, you guys actually are bringing all this hope, and I didn't think it would be such a hopeful discussion. Do you have any messages for that young investigator who may be in a country where there doesn't seem right now to be that level of support or guidance?
Yes, absolutely. So I'd say to all these young investigators and whoever is interested, just get involved. Contact people that are involved in what you want to do, and your passion will solve it all. You'll be part of that bigger group, global group where we're all working the same goal and the same hope and dreams.
Well, the only thing that matters to me now at my age is how young people are going to carry on. And like I said before, there's so much talent on Earth that we just have to release it. People studied biology. People loved biology before NIH existed in 1953. You can always study biology. You can do it with a lot of resources, or you can do it with small resources. And the better and better we understand things, in some ways, the simpler they get. As we turn more biological processes into more engineering, as we gain more knowledge, we can turn them into engineering projects. Once it becomes an engineering project, you can solve it. You can always solve an engineering problem. We need to turn more of our biology into engineering ideas. The F protein and the spike protein, they're just little machines that move around and bring membranes together. So we can turn biology into engineering. As we understand it better, it becomes simpler. Young people need to take what we know now, and a few years from now, maybe when things are calm, they can start rebuilding and take it to a better place.
I think that's a great point to end on. Thank you so much again to our guests, Barney Graham in Atlanta, Georgia, and Gary Kobinger in Galveston, Texas, USA. And thank you for listening to Communicable, the CMI Comms podcast. This episode was hosted by Eren McCreary in Pittsburgh, Pennsylvania, USA, and Angela Huttner in Geneva, Switzerland, editors at CMI Comms, ESCMID's Open Access Journal. It was edited and produced by Dr. Kathryn Hostettler and peer-reviewed by Dr. Eren Ozturk, Ankara University, Ankara, Türkiye. Theme music was composed and conducted by Joseph McDade. This episode will be citable with a written summary referenced by a DOI in the next 8 weeks, and any literature we've discussed today can be found in the show notes. You can subscribe to Communicable wherever you get your podcasts, or you can find it on ESCMID's website for the CMI Comms Journal. Thanks for listening and helping CMI Comms and ESCMID move the conversation in ID and clinical microbiology further along.